Our topic today is the impact of appointment adherence and medication adherence on readmission reductions. And we'll be running through, in our 30 minutes, a very brief overview of digital collaboration solutions, talk about various strategies to address and reduce readmissions, and then talk about various types, the two of the care plan adherence models that you can follow, or strategies, medication adherence and appointment adherence. And we'll look at specific both research and examples of successful ways to do that, and follow with questions and answers. By way of introduction, Digital Collaboration Solutions is a consulting and services company that focuses on care coordination and collaboration and patient and provider engagement solutions. We bring an integrated approach of people, process, technology, and communications to help organizations in healthcare, be it providers, payers, or organizations that support them, to put in place optimal and effective care coordination. We work with those organizations around things like readmissions, and that's what we'll be highlighting today. When you step back and look at unplanned 30-day readmissions, they impact a healthcare organization in three major ways. The first of those is care quality, where there's a range of care quality measurement systems from QBPR, PQRI, HAC scores, meaningful use, and so forth. All of those also start to lead towards financial impact on healthcare organizations. One that is certainly prominent for readmissions is the CMS 30-day readmissions penalty, but readmissions also impacts hospital value-based purchasing programs with CMS, your hospital profitability, your Medicaid spending for the beneficiary, as well as revenue and bad debt for your hospital. And lastly, unplanned readmissions has an impact on patient experience and satisfaction measured by things like HCAHPS and PAM scores. And one of the things that Digital Collaboration Solutions has found is very effective is for healthcare organizations to focus at these three areas and to focus at the measurements that are being impacted so they can understand how actions and strategies that they'll take will have an impact and improve these various measurements. So what are some of the strategies to reduce readmissions that we've seen proven? The first, medication reconciliation, making sure that you know which medications the patient is taking and have that right as they leave the hospital. Medication adherence, which we'll talk about in more detail today. Post-discharge patient monitoring in a wide range of ways, including, of course, med adherence. Post-discharge appointment adherence, which we'll also talk about today, and we highlighted in depth in our last webinar, a recording of which is on the Digital Collaboration Solutions website. Post-discharge care plan adherence, which can be certainly incorporate meds and appointments, but also can be things like physical therapy with addition of hip and knee replacement to the CMS penalty. Going to the PT is a critical part of success post-discharge. And clearly managing transitions of care effectively across the care continuum. In summary, what DCS feels is that you have to have a multi-component, comprehensive care coordination program. And we'll highlight today two of these, medication adherence and post-discharge appointment adherence. The DCS approach starts by saying understand the risk to your organization, both financial, care delivery, care effectiveness, and patient experience. Then look at the impact of those strategies, of various strategies that you might take to address those risks, revenue, cost savings, and care quality improvements. Estimate the implementation cost to implement that strategy. Then you can compute a return on investment and understand whether it's worth doing the strategy. And of course, you have to understand how you're going to fund that strategy. But we hope that you can show financial and care quality benefits to implementing a strategy to reduce readmissions that allows you to make a strong justification that you can fund it, that should fund it. Of course, if you can't show that return on investment, then obviously you shouldn't move forward with a particular strategy. So let's take a look at that through the lens of medication adherence and appointment adherence and what some of the best practices and current activities in the healthcare industry are. We start by looking at evidence-based information of the best approaches to address readmissions. And two studies really jump out for us. A study by Mihai that looks at improving medication adherence and reducing readmissions and their interaction, which showed that a substantial amount of readmissions were affected and caused by medication adherence challenges. This study looked across a wide range of the industry. It was a survey-type study and brings together some of the top research going on in the industry as well as the top results. And then the Journal of American Medical Informatics Association went down in depth and talked about the various types of technologies that can be used to achieve what the previous study talked about. How can you use technology to effectively help reduce readmissions? And we'll look at some of the results that came out of this study where they started with 182 other studies and looked at 30 of those in depth. The Mihai study really said that there are 4 broad models, transition care and transition planning models, in use in the healthcare industry in the U.S. Project RED, the Coleman study, and a couple of others. And they saw a range of commonalities in those studies that said here are ways you can reduce readmissions through medication adherence and appointment adherence. And those strategies revolved around these things. Having a clear, accountable leader or manager to help with readmissions management for patients. Making sure that you have teamwork in place to work across the full care continuum. Understanding how to do medication reconciliation and then clinical management of medications once the patient is discharged. Certainly, patient and caregiver education and engagement so that they know what you're trying to do. Following up comprehensively post-discharge, and effective and appropriate use of automation and around medication and appointment adherence. DCS's approach to that is to say it's an integrated problem. You will not effectively be able to solve the problem if you work on any one piece. Rather, you have to look and say that you're going to combine people, process, and technology and communicate and engage with your patient and provider base in order to effectively implement these strategies and the sorts of strategies that we're seeing in all of the major care management and post-discharge management protocols and models out there. So what are some of the ways you get at that? From a process point of view, you want to take a look at what you do in the hospital, what you're going to do with the patient at home, and what you're going to do with the patient when they come back from various follow-up appointments. So for medication adherence, you want to do med reconciliation. Of course, the physician is going to put in place med orders. Many organizations are doing a med-to-bed or a med-to-home program, which is shown to be effective in making sure that patients are getting the medications they need. That doesn't mean they'll take them, but at least they have them. And we'll argue that you should be doing medication reminder and tracking. And in the hospital, you need to engage that, set that up, and get your patients and their broader care team and families involved. Once patients are home, you're going to do medication delivery. You're going to track their usage. You want to alert them to their usage, remind them, and of course you want to be watching the outcomes and reporting on that and monitoring that to ensure that your patients are getting healthier. And when patients come back to the hospital, you have to review and evaluate. You have to look at a med reconciliation, look at the outcomes reporting, and then change your med orders appropriately. On the people side, you're going to have to engage with the full care team, not just the patient, but the patient, their family members, and other providers that are working with them, like a home health care individual or other types of non-physician clinicians like therapists. Also case management teams in hospitals. Once the patient is home, that group continues, but don't forget to bring the pharmacist and the pharmacy in. They've got data and information and are often an important part of patient engagement and patient and family education. And of course, when the patient comes back for their appointment, you're going to re-engage with the various teams, where in this case, certainly the physician is going to be prominent in their dialogue with the patient. A range of technologies are essential for effective use. You want and are probably using some sort of electronic health record or health information system, and you'd like that to provide a core tracking capability across all parts of the patient's environment, from hospital through home and when they come back for appointments. You also should take a hard look and we'll look at some examples of various types of medication reminder systems that can help make sure that patients do adhere to medication. But again, that won't work if the patients aren't educated and if you don't have a thoughtful process as to how those systems are going to work and how they're going to effectively take their medications. And then frequently we're seeing increased use of various types of care coordination systems that help align and integrate the various electronic health record systems and give your hospital an integrated view of what's going on with patients post-discharge. And you have to engage across the whole gamut of environments the patient's going to be in. Whether they're in the hospital, home, or back for appointments, you need to engage and educate the patient, their family members, and other care providers in the types of medications they're taking, the uses of those medications, side effects, why they're taking the medications. All too often, patients don't understand, do something that's not what they were instructed to because they just don't have the knowledge of why. And frequently, they're being helped by a family member, especially for the elderly and for pediatrics. So when we look at what some of the technologies that are being widely used for medication adherence, we see a range of what the industry wants to call e-health and m-health technologies. And the biggest challenge is that it's all over the map. So lots of us are using telephone, and we frequently will start with live calls where someone in our case management area is assigned to do follow-up phone calls and engage with the patient through telephone technology. Other organizations are starting to use various types of automated telephone capabilities, sometimes called an interactive voice response unit, which can automate those interactions and, if you like, can make them two-way. Certainly the telephone is highly valuable and can work, but doing it with live calls is expensive and only allows you to do those calls when the staff is available. The good news for automated calling is you can schedule it, manage it, watch the results, and so forth. The bad news is not everybody wants to engage in that type of automated call. That leads a lot of the time to two-way text messaging and paging. Pagers are going away. We're more likely to use text messaging. But the idea is to use some type of short messaging capability that does a reminder. They can be two-way, so the patient or the family member or whatever can respond to the message and come back and say, I got it, I am taking my medication, and so forth. In one hospital, we saw an enormous volume, to our surprise, of patients that wanted to use text messaging, including older patients that we would expect would have wanted phone calls. You can email, though lots of people don't want to use email, and the younger set has certainly moved from that to other things, but engaging primary care physicians and other care providers can be done very effectively through email. And we're seeing an explosion of other technology, various types of what we call vital sign monitors. Ones that can be in the home, so think of a blood pressure cuff that stays at home that can capture information, versus all the sorts of wearable devices that are coming onto the market. An example was, of course, just this week, Apple announced their Apple phone device, and it has vital sign tracking capabilities built in. Frequently, those technologies are now able to electronically transmit information up to a central site where it can be monitored and managed, and automated alerts and responses can be put in place. In the medication adherence area, there are lots of electronic drug monitors. Think of them as pill boxes with alarms or connectivity. And frankly, they're coming out of the woodwork with various strengths and weaknesses. The key to these technologies, and to others that we mention here, like digital content to use for education, is to understand that you're going to have to fit them into a process. You're going to have to educate all of the participants in care to use them effectively, and that you're going to have to put those technologies in place the right way. And very often we would find that the best solution is a hybrid approach. You're going to use several of these technologies in an integrated fashion to most effectively drive improvements in med adherence. So some of the things you need to think about are, why are you using med adherence technologies? Are you doing education? Are you working to counsel or coach? Are you looking for monitoring or feedback? Are you looking for electronic reminders? Education is frequently best done by various types of online digital content technologies. And we're seeing things like WebMD and the Mayo Clinic expand and improve their information. WebMD recently announced how they'll have much more live video on their site, showing people more effectively how they can do various types of post-discharge protocols. If you're trying to do something like monitoring, some of the new devices, the wearable devices, are becoming more and more effective and less expensive, and allow for vital sign monitoring with very little intervention or effort on the part of the patient or other caregivers. And of course, the reminder capabilities, whether a pill box or text messaging, can be effective, but you do have to watch out for what people call alarm fatigue. If patients are being pinged all the time, they might just ignore it or turn it off. That leads us to the usage model. Are you going to do automated work? Is the patient going to direct the activity, or is the care team going to direct the activity? And you need to understand what the right approach is so that you can use the technologies you choose in an integrated hybrid fashion most effectively. And then you want to measure, measure, measure. You want to measure adherence to the technologies and adherence to medication, whether it's self-reported, prescription refills, drug counts, or in some cases you can actually do things like blood work to regularly understand the impact of medication. And you want to measure outcomes as best you can, whether clinically, disease symptoms, or various types of self-reported outcome measures. When you put these together, you'll have the most effective ability to impact medication adherence and as a result, reduce readmissions. So what are some success factors for medication adherence? We like to look at it and say it's the use of these innovative technologies plus best practices to make them work in your healthcare organization and with your patients. Clearly define your goals, adherence goals and clinical outcome goals. Know what you're trying to do. The technologies and the processes that relate to them must work effectively for the users, patients, family, and care teams. They have to be comfortable and understand the technology. They have to have ability to access the technology. For example, if they don't have internet access, some of these technologies just won't work. And they have to have the right level of education and knowledge to use the systems well. If the patients, if the users don't understand what's going on and can't use things effectively, technology will not work. That doesn't mean your processes aren't going to come into place and that you can't put in place other types of processes to help. For example, live phone calls or on-site visits by care staff. Those will certainly work, but again, you have to understand how that's going to engage and work with the various user base. All of this means you're going to have to integrate a comprehensive and hybrid workflow. It's what the care workflow is that's going to determine the effectiveness when it's all said and done. And then you're going to have to make sure that the technologies work together both with each other and with the workflow. For example, are you going to be able to use the technologies and collect the information you want in the electronic health record system so providers have an integrated and comprehensive view of patients? Recognize that this is not simple, but on the other hand, try not to make it overly complex. Pick a spot that you can deliver results and start there, and then move step by step to more comprehensive programs. So turning from medication adherence to appointment adherence, again, there's a wide range of academic studies. For example, the American Heart Association that showed that good post-discharge appointment adherence can have a dramatic 2.8+% decrease in 30-day readmissions. And one way to look at that is to look again at the workflow, that when the patient is in the hospital, you want to, of course, make a follow-up appointment for the patient, and you also want to engage them in how are we going to make sure patients that you get back. Good best practices would say it's not just the patient that's going to get themselves back to for a follow-up appointment. It's going to be the patient engaged with other members of typically family or their care team. And you want to identify, or we call them, enroll them in the follow-up approach that you're going to take so you can remind the patient and their care team about a follow-up appointment. Then when the patient is home, in what we call the vulnerable period, you want to make sure that you're doing a comprehensive reminder. Many organizations and hospitals will have somebody do a follow-up call and say, hey, want to just make sure you're coming back for your appointment. We find that you can do better through a more comprehensive, often technology-driven solution to let you remind patients and family members on the device of choice and their language of choice and give you two-way reminder capabilities. Those patients who don't respond, that you don't hear from, those are the ones that you can then use your limited staff to follow up and say, hey, what's going on with this particular patient? And of course, success is that on appointment day, your patient is there in the doctor's office, typically within 7 days, and some of the studies for cardiology suggest 3 to 5 days is optimal. And interestingly, what's often happening at that appointment is adjustments to medications as you do a med reconciliation and as the physician reviews medication dosage and selection, and that puts you right back into the med adherence side of our discussion. When we've looked at effective appointment adherence, one case study is Hahnemann University Hospital in Philadelphia, a 500-bed hospital where quality automated appointment adherence using a two-way multi-device and multilingual system reduced readmissions by some 40% from a previous period baseline of 26+% to 16% during a pilot program, and relative to a control group of reducing relative to the control group from 21% to 16%. That had an enormous care impact on the patient base, and Hahnemann is expanding that program to cross a wide range of other discharge and both in cardiology and other diagnoses that are subject to the CMS penalty. On the financial side, these are not the actual numbers for confidentiality purposes, but a hospital like Hahnemann could save several $1 million in penalties just from that sort of decrease in readmission. And in addition, if you look at other financial impacts of readmission, good appointment adherence like this can have additional financial benefits. So we've seen that good appointment, post-discharge appointment adherence often help through, again, that people, process, technology, integrated result can have both care quality and financial benefits to the hospital. So what do we recommend in summary? The first is medication and appointment adherence are shown by literature to reduce readmissions. Appointment adherence is probably more proven. There's very clear examples of that, such as the study that we mentioned in the American Heart Association, that you can get the sort of results you want. Medication adherence, more complex though, because of the multitude of process activities. You're not just getting someone back, you're trying to get them to do something day in and day out, and sometimes multiple times a day, which is take their medication the right way, on time, and the right dosage. But they can have serious impact on both care quality and financially. Technology can help. It can increase consistency, reduce costs, and allow your staff to focus at your highest risk patients. So if appropriately implemented, it can have an important part. You must educate and communicate with all of the people involved, patients, family members, caregivers, both home caregivers and office-based and hospital-based care team in order to have effective impact on post-discharge appointment and medication adherence. And these solutions are best when they're integrated and often hybrid. You need to integrate the solutions across the care continuum. The patient is going home, or they're going to a rehab facility, or they're going back to a SNF, or they're going to be working with a home health aide. So you need to think about who's involved. You therefore have to integrate across the full care team involved with the patient. When you're using technology, you want to think about integrating the various parts of the IT systems that are going to be used. And you need to think about integration across the time frame. What happens in the hospital? What happens when they're in another tertiary facility? What happens when they're home? What happens when they come back for an appointment? So that you have a comprehensive continuum related to helping make sure that you have med adherence and appointment adherence post-discharge. We certainly suggest you start with one thing. It's don't boil the whole ocean, but think about it as, I'm going to pick this place to start and get going there, and then you can always expand. And if you have any existing initiatives in this area, and most hospitals do, make sure that you integrate new ones within those. So if you're using, for example, staff to do follow-up, case management staff to do follow-up calls and so forth with your patients, Ask how automation will help them do a better job. Ask how you can put in place monitoring technology to see that the patient is using medication. Ask how you can integrate with the pharmacy to make sure that medication is being refilled. And can you do that with something other than the telephone? So in summary, medication and appointment adherence post-discharge can have a marked impact on post-discharge readmissions, which can have both care quality and financial benefits to hospitals. And you have to look at a comprehensive and integrated multi-component program in order to have effectiveness.